Joint Commission readiness, part 4. So always the Joint Commission will want to know that the staff know what their data is as far as HAIs and performance improvement. They want to know what are the performance improvement projects, not only what are they, but what exactly are we doing to improve our performance. So we are always working to decrease the CAUTIs in our unit, so catheter-associated UTIs. So how are we doing this? So every day we are assessing, does this patient really need a Foley? If they don't need a Foley, we're taking the Foley out. This is a nurse-driven protocol, which means we do not need a doctor's order. Foley care is Q shift, so please make sure that we're doing chlorhexidine Foley care, that we are coating the Foley with chlorhexidine foam. You do not need to remove that foam, just leave it there. I actually want to do that with all drains, so JPs, any drains, you can wipe them down with CHG, wipe away from the patient of course, but coat the drains with CHG. That will really help cut down site infections. What else do we do? So we make sure that we keep the bag lower than the bladder, right? So especially on transportation, you want to make sure that there's no kinks. We use IC Foleys, and we empty the bag when it's half full. Generally speaking, our ICUs do an incredible job with HAIs. Each unit will have a display board, and we need to know where that board is and what the data shows. It's always nice to take the surveyor to the display board and show off our data. Okay, so CLABSI rates for the units are also exceptionally low, especially given the acuity of our patients. And that's really a testament to the incredible care that you guys give. These patients are complex and complicated and at such high risk, and to have 0 CLABSI for 2 years is truly amazing. There was a slight uptick over the COVID years, but truly the numbers have stayed remarkably low. So what do we do to reduce the number of central line infections? So of course, daily review. We always try to get rid of a central line if we don't need it. If we have a femoral line, we transition it to something else. Strict hand washing, Kuros caps. We should also be able to speak to the fact that we do a timeout before any insertion of a line, and that we are empowered to stop the procedure if there is any break in sterile technique. Because the institution has identified that we have a problem hospital-wide with dialysis catheters, our colleagues from the dialysis unit round on us a couple times a week and identify any opportunities to do better with the dialysis line dressings. The opportunities that we see here are to make sure that if you have a line that is oozing, your patient is coagulopathic, that you don't try to use a biopatch dressing on that. Use a gauze dressing and change it PRN. By policy, it's every 24 hours. Also, if the biopatch is on, it has to be wrapped around and behind the catheter, so don't let it just float on top. And as an editorial note, this is a very bad habit that we see. Do not attach saline syringes to your lines, even if it's for a short period of time, because bacteria will multiply in these syringes very, very quickly, and it's a hazard for us, for our patients. Okay, next is preventing MDROs, and we're talking about C. diff, MRSA, VRE, and now unfortunately we have Candida auris to worry about. Here we can talk about a lot of things, but decluttering the environment, disinfecting any equipment in between patients, the use of UV lights when we terminally clean the rooms. We can talk about the chlorhexidine CHG bath that we give to the patients daily. Specific to C. diff, we post special precaution signs, the brown ones, and of course you know that we use soap and water for C. diff. For MRSA, in addition to the CHG bath, you could mention the nasal decolonization that we do with Nosin Q12, that mouth care is done with Q4 hours for patients with artificial airways, and Q6 for anybody that's not intubated, that we give hand wipes to the patients who are awake. And for our new friend, Candida auris, that we are screening patients on admission if the patient comes from an outside facility, specifically because we have these transplant patients, that we're bathing our patients with CHGQ12, and that we are wiping down our environment every 12 hours. C. auris is very concerning because it's very, very difficult to get rid of once you've got it. And we would put these patients on contact precautions with the lowest possible ratio in a private room. Okay, again, where is the infection control manual? Just like the policy manual, the Lippincott manual, you will find it in content directory, and it's probably a good idea if you go ahead and locate those things so that if you're asked, you will not have to be scrambling.
SICU team. This short video is about clean supplies. Every day I come in, I have to end up returning all these supplies. Believe it or not, this is not my job. Can you please, when you come on at the beginning of the ship, take what you need, and when you're done, return what you don't need, what you don't use. Thank you.
Okay, as everyone's saying, this is everybody's responsibility, not just his and the PCTs or the A&Ms for that matter. We really need everybody to get on board, and we have a mountain of supplies every day, so please, it has to stop. Okay, so last but not least, one of our perpetual performance improvement projects would be preventing pressure injuries. In our ICU, we have a lot of devices, so naturally we have to focus on those devices to make sure that they don't cause any injury. Nasal cannula, high flow nasal cannula, the pulse oximeters, the ET tubes, the trach phalanges, ECMO cannulas, you name it, we've got a big risk. You know, it's pretty obvious why these devices are hard plastic, they're hard to secure, it's hard to see under them. Sometimes there's bad positioning or the device is not fixated right. You know, the size of our patient actually fluctuates due to edema. Our patients have every comorbidity in the book, and you know, most of them have really very, very bad perfusion. So we should be able to speak to how we pay extra attention to positioning and padding wherever possible to mitigate the damage from these devices. And heels. Heels are always high risk for pressure injuries, especially for DTIs. So we should be able to speak to how we take extra care to float the heels at all times. We just have to make sure that they really are free floating and that there is air between the heel and the mattress. And funny thing how patients move around, so you just have to continually check every time you're in the room that you still have your heels floating off the mattress.